Okay, welcome everyone. Thank you for joining us. Our webinar today is the GI Effects and NutrEval Making Clinical Connections. Our speaker today is Dr. Stephen Goldman. My name is Warren Brown, Clinical Science Liaison for Genova Diagnostics. I'll be serving as the moderator for today's webinar. We'd like to welcome Dr. Stephen Goldman. Dr. Goldman earned his Bachelor of Science degree from the University of Massachusetts. He received a Doctorate of Chiropractic from Cleveland Chiropractic College, where he also served as a member of the faculty. Following 25 years of family practice in Los Angeles, where he worked largely with athletes and patients concerned with optimal health, Dr. Goldman relocated to Asheville and joined the medical education team at Genova Diagnostics. As a medical education specialist, Dr. Goldman provides educational support to physicians and also authors medical education support materials. I've worked with Dr. Goldman for about 3 years now, and it seems like he always has something insightful to contribute to our case discussion, so I'm looking forward to this presentation as well. One of the most common questions asked during our live GDX webinars is about the availability of the presentation and the slide deck. These materials will be available on our website within a week following the webinar. You'll find them under the Clinicians tab on our website, right under the Medical Education button, or by logging onto your MyGDX account. And if you don't have a MyGDX account but would like to set one up, just click the Getting Started link on our homepage. Now I will turn things over to Dr. Goldman. Dr. Goldman, I will make you presenter now.
Hi, thanks everybody. Thank you, Warren. As said, I'm Steve Goldman, and I'm part of the medical education team here at Genova Diagnostics. And a lot of you may know me from doing consults on the phone, and I think my best approach here is to try to make it very much like those consults on the phone, where we're going to tie the GI effects and the NutrEval together in terms of a couple of case studies. So it's really going to be very much like how we would do a consult, how we would evaluate a patient utilizing all this data from these tests. So the objectives for this presentation are specifically to identify concepts that connect nutritional assessments and stool testing results, to provide interpretation and application of laboratory results, and to discuss strategies that are helpful for treatment plan creation. So this is an abstract that I pulled, and it's not hard to find these nowadays about the microbiome as being a key to understanding health and nutrition. So in this abstract from 2018, it indicates that the human microbiome has emerged as the crucial moderator in the interactions between food and our body. The causes of disease are often only partially understood. However, nutrients, metabolites, and microbes are increasingly regarded as key players, even where the complete disease mechanism remains unclear. In other words, the gut through the GI effects and nutrients through the NutrEval are going to really give us a great deal of information. And so what I want to do is jump right in to our first case. I have two cases that I wanted to present here. Case one involves a 42-year-old female. She complains of loose stools over an 18-month period of time. Now, she's been scoped. There's been endoscopy, colonoscopy. They were unremarkable. There's a rapid transit time. Dry skin with brittle nails. Immediately, my mind starts thinking about thyroid and nutrient support. Stress is moderate to high. The standard American diet craves sweets and medication specifically for diarrhea occasionally. So that's our first case study. Now, let's take a look at the tests that we're going to be using. There are two tests, as I said, the GI effects, the stool analysis, and the NutrEval. So when we look at this GI effects, the front page, we started with these functional pillars of health: infection, inflammation, insufficiency, and imbalance. And the idea here is to just give the doctor a chance to look and see what were the highlights. We're going to go through all these markers in a consult. We'll look through the whole thing, but we can see that there's some inflammation based on the secretory IgA, that there's some insufficiency, some imbalance within the test that we're going to want to really look at. And then the second portion of the test, which is the global gut health markers. Now, these are the commensal balance on the left and the relative abundance on the right are based on DNA findings. And so I just want to briefly explain, and I know a lot of you may have heard other webinars on the GI effects, but the reasoning behind doing these commensal 24 DNA findings. Remember, the vast majority of bacteria in the gut are anaerobic. They live on low oxygen, and that makes them very, very difficult to culture. So since we want to get a good look at the commensal balance, at these commensal anaerobic bacteria, DNA is a great way of getting a quantitative read, getting a number for bacteria that would be very difficult to culture. And that's why we have this portion, the commensal balance and relative abundance, to be able to extrapolate what the gut microbiota, which is predominantly anaerobic, predominantly located in the colon, how does that look? So we have the commensal balance on the left and the relative abundance on the right. And in fact, looking at that relative abundance, we can see that the healthy cohort relative to our patient has a pretty high abundance, a pretty well-populated place. And we'll talk about that as well. So this is that front page. And again, under inflammation, we see the IgA elevation. We see pancreatic elastase low, the arrow pointing down in terms of pancreatic enzyme secretion. We see imbalances, potentially there's more than one, based on that red arrow, potentially pathogenic bacteria that grew out in the culture. We see low N-butyrate, which is one of the short-chain fatty acids, and an elevation of an enzyme called Beta-glucuronidase. And again, we'll look through those as we go through the test itself. As far as this commensal balance and relative abundance, again, when we look at that relative abundance on the right, you see that box on the bottom right-hand corner, and it has the various phyla that we will look at on the commensal bacteria page. We color-coded it, and then we took a healthy screen cohort and put that column, that graphic, healthy cohort. And then we took this patient's results and did the same thing. And what we see here is that the patient's relative abundance in terms of these phyla, these anaerobic bacteria, relative to a healthy cohort is even greater, a very populated microbiota. Now, what does that mean? It could mean a number of things. Sometimes it's a good thing. Maybe they're eating fermented foods, maybe probiotics and prebiotics. But sometimes we see a pattern like that in a SIBO case as well. So we'll keep a watchful eye on any hints around those. As far as the commensal balance on the left, we know that a lot of people have done this test in the past. And we decided that we wanted to provide doctors with the opportunity to really compare their patients' findings for the 24 DNA findings to patients that have done the test in the past. Now, when I'm on the phone, some of you have asked the question, like, why does this look different? And it looks different because we do provide those opportunities for the commensal balance, for example, to compare with other patients. So if you look at this, you'll see a green, yellow, and red configuration. The green and yellow is those patients in terms of distribution of commensal bacteria from DNA who are healthy. To be in the red, and you see we are here, would indicate more alignment as far as the balance of the microbiota towards an unhealthy individual. So what do we compare with? So here's the commensal balance and relative abundance. Here's our commensal balance. And if you look at the bottom, that 0 to 24 is the x-axis. It's the reference variance score. It reflects the total number of an individual's patient's commensal bacteria results that are out of the reference range. In other words, when we look at this from that 0 to 24, 24 commensals from DNA, we can see the diamond is right over that 8. And that tells us that when we get to that page of the commensal findings, that there were 8 of those commensals that were either high to the reference range or low to the reference range. So that's one criteria of comparison to people that have taken the test. And the second is the y-axis, the healthy pattern continuum. This used to be called the diversity association for those who remember that. That's 0 to 10. And it's a calculation utilizing targeted DNA findings run through an algorithm. And the higher from 0 to 10 you go, the more likely that you have a distribution of a healthier microbiota, a healthier individual. And to make that point, if you look at the green, for example, you can see that you can be at 0 and in the green and still be in that healthy green zone. But the higher you go towards 10, the wider that distribution, the more likely that you have a healthier gut commensal balance. So by that X and Y axis, we're able to compare your patient's findings to findings of patients that were both healthy and unhealthy that ran the test in the past. And again, we see that that black diamond is just getting into the red towards a more unhealthy balance. Now, there are two other areas that have changed in terms of what's on the test. And again, all of them are about the DNA findings, just to give you an opportunity to compare your patient's findings to findings of people that have taken the test. The actual markers on the test have not changed at all. So we have this biomarker clinical association chart. So these biomarkers were found to have relevant associations with clinical conditions. And so if you look at this, you'll see these are the findings, the highs and lows, all of them high here for this patient as far as these various bacteria. So if you have a patient that comes to you and you think, well, you know, I'm seeing a pattern, a clinical pattern, perhaps IBS, you could look at this and say, well, how does this patient's findings compare to patients who have done this test in the past with diagnoses of IBS relative to patients that were screened healthy cohorts? This is not a diagnostic test, it's a pattern analysis. So these are associations that are part of an ongoing research program. It will most likely evolve over time as data accrues and is refined. So this is a continuous project and reported for informational and clinical interest purposes only. So if your patient has a high Bacteroides prevotella at the top, it doesn't mean they're going to get IBS or IBD or any of these. It just means we're looking to compare patterns. And there you see it again. There's IBS as an example. The blue arrows pointing up speak to an elevation, pointing down lower for patients with IBS. And it's just a way of pattern analysis. And the third place where we allowed for that or provided the opportunity to compare is this portion of the interpreted glance where we look at all the markers on the test, the pancreatic elastase all the way through beta-glucuronidase. So you see with the pancreatic elastase is low, we actually saw that across the board. Triglycerides high, you can see various situations where that might, in a pattern, be problematic. Again, these are not diagnostic, excuse me. They are patterns that we look for to get a sense of the overall balance and what it may be telling us. So let's look at the results themselves. And for those of you who have done the GI effects for a good long while, this is very familiar. None of this has changed. So when I look at digestion and absorption, the pancreatic elastase 1 is a really good indicator of pancreatic enzyme secretion. You want to be at least over 200 based on this reference range. And what you're seeing here is a low 98. So that is a finding that I'm going to take note of low pancreatic enzyme secretion. Beneath it, the products of protein breakdown are valerate, isobutyrate, and isovalerate, and they're kind of on the lower side. These typically elevate if a patient is having difficulty breaking down and absorbing protein with transit time issues sometimes. But overall, this low number is not alarming. A high number would certainly get my attention in terms of possible problematic protein absorption. The fecal fats are a little bit on the higher side overall if you look how they're skewing to the right. And this is a very similar concept. So as this patient is eating fat in their diet, are they breaking it down? Are they absorbing it? Because if they're not absorbing their fats, they will end up in the stool in higher and higher concentrations. And that's what we're looking for here. And I would say that, yes, we're seeing some indication of an elevation of fecal fats here. So perhaps we need to think about things like pancreatic enzymes, especially with lipase. Maybe there's a bile situation. Ox bile might be useful. Maybe there's a liver issue in terms of the production of bile. And maybe we are dealing with SIBO, where a bacterial overgrowth in the upper gut can sometimes erode the bile salts and leave us with more difficulty in terms of bile and the breakdown of fat. So a lot of possibilities here, but as always, this is detective work and we're always looking through the data. When we look at inflammation and immunology, remember that the endoscopy and colonoscopy were unremarkable when we talked to the patient. And so when we look at these, the calprotectin at less than 17 is exactly where we want to be. Calprotectin is a valuable tool on this test. It reflects neutrophilic increases. And so when you see a high calprotectin, you think inflammation. When you see a high calprotectin, that's when you might want to scope, because calprotectin is never a substitute for a scope. but it's a very important inflammatory marker. So am I thinking inflammatory bowel here or more towards irritable? Well, based on this calprotectin, inflammatory bowel is far less likely. Eosinophil protein X, another inflammatory eosinophilic marker that when increased speaks to things like worms, parasites, allergies. Below detectable limit is just fine. Now the fecal secretory IgA is a bit high at 941. IgA antibodies live in mucosal tissue, and mucosal tissue line the gut. So oftentimes, if there's something irritating to the gut, fecal secretory IgA can be a first responder as far as immunology. We saw on the front page that there were issues around potentially pathogenic bacteria, yeast, bacteria, transit time, a lot of things that can irritate the mucosal lining can create an elevation as we see here. Now, the gastrointestinal microbiome section, the short-chain fatty acid total of acetate, butyrate, and propionate are low, right? And that's important. These tend to be beneficial. And butyrate, for example, which is also low, is utilized by colon cells for the production of energy, preferentially over glucose. So we want to see a more robust short-chain fatty acid total. These are made by anaerobic bacteria breaking down fiber. So in this case, you think in terms of maybe there's a need for fiber. Maybe there's not enough fiber there. We had a pretty high relative abundance on the first page. So possibly probiotics and prebiotics, but certainly fiber. And another marker here that makes me think along those lines is that beta-glucuronidase. You see it's really very high at 15,727. In the literature, elevations of beta-glucuronidase have some association with the risk of colon cancer, hormone-related cancers like breast cancer. And the reason is that this is an enzyme that recirculates toxins in the gut. So that if you're taking in toxins, including sex hormones, any kind of substrate that needs to be detoxified can go down these various detox pathways. Beta-glucuronidase is an enzyme that will recirculate those toxins, and thus the risk. In order to bring it down, you think in terms, as I said, of more fiber. You might also consider the utilization of calcium D-glucarate. You see it at the bottom there. Calcium D-glucarate is not known so much for lowering the level, the substrate of beta-glucuronidase enzyme, but it is known to inhibit its action, to reduce its action. So when you see a high beta-glucuronidase, think recirculation of toxins, think fiber, think calcium D-glucarate to inhibit its action. Now, here's that DNA read on the commensal bacteria. Here are the findings for those 24 bacteria. And we already know a lot about this, right? Because this was the data that spoke to a high relative abundance. It spoke to a commensal balance that was more distributed toward an unhealthy individual. That all came from this page. Now, I say here DNA and quantitative. Remember, anaerobes are hard to culture. Using DNA allows us to get a quantitative read, to get a number. This allows us to get a sense of the gut microbiota, since the vast majority of it is anaerobic. So when I look at this page, there are three anaerobic bacteria that I tend to keep a watchful eye on. Lactobacillus, which even as I say anaerobic, I have to add, can also be aerobic. And if we look at the lactobacillus here at 1.2 e to the 9th in the 4th quintile, quantitatively, that's a pretty good number. If I go down to the bifidobacterium species, we can see that's just in the middle of the 3rd quintile. It's moderate. Now, no alarms going off here, no red letters, but I would say that you may consider that the patient could do better quantitatively in terms of their bifidobacterium presence. And then finally, the E. coli, a good E. coli, that is high. So that's not problematic. So those three are the lacto, reasonably robust quantitatively, bifido moderate, and the E. coli pretty strong. Now, whereas DNA is quantitative, where we're getting a number, culture is about viability. It's about growth. You have to be pretty tough to grow out in a culture dish in a laboratory. Now, to be completely transparent here, lactobacillus is really difficult to grow. And as a result, a no growth finding is not that unusual on a culture of lactobacillus. However, in this test, we have the luxury of that DNA finding. Quantitatively, there was a good presence of lactobacillus. So I find that encouraging. The E. coli and bifido, on the other hand, grew out really strongly. Remember, the bifido was only moderate quantitatively, but we see it's a strong strain, which to me is all the more encouraging that bifido would do well with probiotic support. And I make these points because a lot of people look at these tests and they'll see a difference between what's on the DNA finding and what's on the culture for these three. We had to specifically set up these three. And it's that difference of quantity versus viability, but it gives you a deeper insight into these three. Now, the next thing we do is we take that stool sample and we will put it in a culture, and whatever grows out, grows out. In this case, we see that Citrobacter species, Bacillus and Citrobacter, all have that yellow on the right. The Bacillus and Citrobacter that you see at the bottom are all in the yellow. So we designate that at PP, potentially pathogenic. And we'll provide sensitivities if you decide to treat that. The Citrobacter species is at 3+. 4+ would have gotten it into that yellow, and it would have changed the designation to potential pathogen. I bring this up because we can't know that it has to be 4+. Every patient is different. And so if you have a patient and their clinical picture says, I want to treat that, I see that yellow, that's the treating physician's decision to make, certainly. And then what we did next was we took that stool and put it in a culture specifically for yeast, and that's the mycology, and there was no viable yeast growth. So our parasitology, unremarkable. If you give us 3 specimens, we blend them, filter them, and look under a high-powered microscope. No over-parasite seen. EIA test specific to Cryptosporidium, Giardia, and Entamoeba, all negative. And then the add-on results for this GI effects. Fecal occult blood negative, color brown as reported by the patient, formed in normal, consistency as reported by the patient. H. pylori was negative. Notice the Campylobacter and C. diff were negative. Those are good tests to run as add-ons when diarrhea that's somewhat unexplained shows up. And so that's why I wanted to make sure that we highlighted that. So that's the GI effects. And we saw a number of things in terms of need for pancreatic enzymes, higher fecal fats, IgA elevation, low short-chain fatty acids and the need for fiber, the high beta-glucuronidase and the need for fiber, and potentially pathogenic bacteria. So that's one point of view. Now let's look at the nutritional point of view via the NutrEval. So the NutrEval has this front page, and basically it's a great way to get a sense of what are the headlines. So as far as the borderline and high need for all these antioxidants, I'm thinking that antioxidant support matters here. As far as B vitamins, look at all those B vitamin needs in both the borderline to moderate and high need. So this would be another headline. And when I see a lot of B vitamin needs, I start to wonder about detoxification. It's hard to methylate without strong B vitamins. And then, of course, the magnesium and zinc are moderate, very, very key mineral cofactors. So that's what I pull out from this first opening page. What are the headlines? The second page has a suggested supplement schedule. And if you look at it, you can see that, remember, we looked at that GI effects and the need for probiotics, pancreatic enzymes. Well, here we go, right there. Now, these are always going to have some variation. Well, we'll generally have variations, but we can see a very strong message here of digestive support, probiotic, pancreatic enzyme need. Remember, we had the commensal balance that was low. We had insufficiency of pancreatic elastase and a number of imbalances. So what about the organic acids? We can see that when we look at malabsorption and dysbiosis markers, elevations of these organic acids speak to dysbiosis. So when I see those elevations, I know that anaerobic bacteria are creating elevated organic acids. Now, if I'm going to compare these organic acid findings of dysbiosis relative to the GI effects, the GI effects is always going to be my gold standard. As far as vitamin markers, these are functional recommendations. So elevations of these organic acids speak to specific cofactor needs, including B vitamins. For example, that xanthoranic acid. Xanthoranic acid requires vitamin B6 in order to be broken down. If it doesn't have adequate B6 functionally, then you're going to have an accumulation in the blood of xanthranic acid that will get kicked into the urine, and we'll see an elevation like we see for this 1.28. Same with the glutaric acid. All of these are monitored by the algorithm, and they are always going to be hardwired into the B vitamin recommendations. Also, in toxin and detox markers here, we have this organic acid, alpha-hydroxyisobutyric acid, from MTBE, which is elevated. Now, first of all, let's be clear. We're talking about exposure. So there was an exposure based on this elevation of MTBE. This is a gasoline additive that found its way into the water and into the soil. It's water soluble, which is good news, so generally not stored as body burden, but it speaks to an awareness to address and help with detoxification. And then the amino acids. The first thing I'm going to look at for the amino acids are going to be the essentials. They come from food. How do they look? The overall pattern looks pretty strong. Most of them are kind of in the right side. A few of them are elevated. And then the question I ask is, how does that compare to dietary intake? And the way I get a sense of that is through this 1-methylhistidine. You see how high that is. 1-methylhistidine is a good indicator of dietary intake of protein from fish, from fowl, from meat, fowl being chicken, turkey, duck. Also, the urea I notice at 404 on the top right is pretty robust, and typically higher protein leads to a higher urea finding. So the essential and metabolic fatty acid markers here, I go right to the bottom of the page. That omega-3 index speaks to a low index. Ideally, you'd like to be between 8 and 10 here. So at 3.4, that speaks to a need for omega-3s, and you can see that on the page as well. The omega-9s look fine to me. The saturated fats through the overall percent of saturated fats look fine. The omega-6s are kind of interesting. If you go to the next page on the test, you'll see on the right, people tend to avoid the omega-6s because of the fourth box, the arachidonic. Because arachidonic acid is an omega-6 that's pro-inflammatory. So my goal here is to keep that just about where it is. But what I also want is, I want the dihomogammalinolenic, the DGLA, to be in the green. Because DGLA, although an omega-6, is a very strong anti-inflammatory. So how do I add on to that DGLA? Well, if you look at the box above it, the GLA, I know that looks like a Y, that's a gamma, is what converts. GLA has to convert to DGLA. So in that box, it indicates evening primrose, borage, blackcurrant. Those are great sources of GLA to increase the substrate. Also, the blue arrows representing the delta-6 desaturase and elongase enzymes speak to a need as well of some of the B vitamin recommendations that we saw on the first pages of the NutrEval. So get up that DGLA for anti-inflammatory, get up the omega-3s as anti-inflammatory, and maintain a moderate arachidonic acid here. That's what you're aiming for. As far as oxidative stress and detox, the glutathione is rather low. So perhaps glutathione supplementation, glutathione as an antioxidant and detoxifier, essential. And then the lipid peroxides. Lipid peroxides are measurable oxidative stress damage. So that when you have an elevation of lipid peroxides, that means there's oxidation of lipids, of cell membranes going on. And between the low glutathione and the high lipid peroxides, that's really driving the antioxidant recommendations. Now, we mentioned a moderate need for magnesium and zinc. In this case, both of them look a little low in the reference range. Such key cofactors. So supplementation of magnesium and zinc would certainly be on my list of things to do. As far as the toxic elements, the lead through tin, what we're looking at here is, again, exposure. And it's all whole blood for these toxic elements. So whole blood, generally around 120 days or less exposure time is what we're looking at. All right, so we've looked at the GI effects, and we've looked at the NutrEval. Remember, we had a 42-year-old female, loose stools, scoped and negative, rapid transit time, dry skin with brittle nails, stress is moderate to high, think cortisol, standard American diet, craves sweets, and on a medication for diarrhea occasionally. So what are our treatment considerations? Well, I would continue to monitor that thyroid. certainly with the brittle nails and the skin, that's something that you want to make sure is in balance. Although we talked about that high stress, and the third from the bottom, follow up with an adrenal cortex stress profile with cortisol awakening response, or CAR, because remember, high cortisol can really lower thyroid secretion and production. So these are all related, and that's why following up with an adrenal cortex stress profile with CAR is a great way to go for more data. You want to balance the gut with prebiotics, probiotics, assuming we're not dealing with SIBO, because in SIBO, if you increase the fiber, you can actually increase the abdominal distension and symptoms of SIBO. So a SIBO test is often utilized just to eliminate that, because remember, we're saying because of the short-chain fatty acids being low and the beta-glucuronidase being high, that they need fiber. But I would certainly consider holding off on the fiber if I was treating a SIBO patient. Omega-3 supplementation, DGLA support through evening primrose and barrage, the GLA to convert into DGLA. Consider liver detox protocol to help them. Also, remember we had that low glutathione that we wanted to support, and thus also antioxidant support, vitamin E, C, lipoic acid. So what we have here is a combination of the NutrEval speaking to some of these needs very specifically, and also, of course, adjusting to a more balanced diet. That's always going to be a key. Just mentioning the NutrEval brought me right back to that. And I think about a Mediterranean-style diet as something to really consider for your patient. When a patient has sugar cravings, something's amiss in their diet. So we've taken the NutrEval and we've taken the GI Effects, and with that data, we've been able to really look at this case from a different point of view. And I think it's really very, very helpful. And I wanted to make sure we got in our second case as well. So in our second case, number 2, 35-year-old female, fatigue for a year, Hashimoto's, treated, so thyroid seems balanced based on lab results at that point. Occasional non-specific abdominal pain with loose stool, a 32-day cycle, occasionally irregular. Endoscopy and colonoscopy were unremarkable. High stress, lots of grains in the diet, a low protein intake. It'd be interesting to see how that shows itself. And there are medications for thyroid and selenium, omega-3 fish oil, and a daily multivitamin. So this is case number 2. So let's look at the GI effects. Any imbalance? Well, yeah, M-butyrate was low, short-chain fatty acids were low, M-butyrate being one of those. A potential pathogenic bacteria that grew out, a beneficial bacteria that was low in the DNA, and we'll look at all of that. What about the commensal balance? Well, it looks like there were 4 different commensals that were either high or low to the reference range, and overall in the yellow that the commensal balance wasn't bad relative to healthy and unhealthy individuals who have done the test in the past. But what about the relative abundance? This time, when we compared the healthy cohort's DNA findings to the patient's results, look how low the patient's results are. So right away, I'm thinking about something that really diminished the population and the need to really rebuild and replenish the gut microbiota here. We don't really have enough of these results. 4 low results isn't a lot for us to get any kind of interpretation around patterns. So let's go right to the data here. Now, when we look at the digestion and absorption findings, the pancreatic elastase at 227, it got past that 200 mark. I'm a stickler for detail. I like it to be a bit more robust when possible, but at 227, we've made it into the reference range, but it does get my attention. The products of protein breakdown are kind of on the lower side at 2.8. But if we think about these products of protein breakdown, often coming from protein that's not fully broken down and absorbed, that becomes fermented, remember, this patient's on a really low protein diet. So I wouldn't expect the products of protein breakdown to be very high in someone that's just not taking in much protein. As far as the fecal fat total, moderate overall, so not a really high fat content overall as far as fats, a little different from the case we just looked at. As far as the calprotectin, eosinophil protein X, and fecal secretory IgA, nothing remarkable here. So as far as inflammation and immune response, nothing really showing up. Now, again, when I see that calprotectin like this, I'm happy, but we also know that this patient did have a scope and that it looked very good. So that's all, that all makes perfect sense. But what about these short chain fatty acids, this total? Really, really low. Now, remember, these are beneficial. Acetate, N-butyrate, and propionate. They're made when anaerobic bacteria break down fiber. So we're thinking, first of all, this seems like a pretty depleted gut microbiota. So I'm thinking fiber and probiotics, prebiotics are going to be really key. Building up the microbiota and providing enough fiber to make more of these short-chain fatty acids. And I would point out N-butyrate, which I had mentioned earlier, in the short term can be supplemented. But in the long run, a balanced gut with a good balance of fiber should maintain a good N-butyrate. You can see that there are the percentages of the N-butyrate, acetate, and propionate. They look pretty balanced here. I tend to look at them as an indication of imbalance when they're really skewed very high and very low, because again, anaerobes are making these by breaking down fiber. So if they're skewed, it makes me wonder about that balance. The beta-glucuronidase in this case looks just fine at 2,182. And now the quantitative commensal bacteria. So for these commensals, we can see the lactobacillus here is only in the first quintile, which is a bit on the low side. The bifido is really very low. And the E. coli seems just fine. So again, quantitatively through DNA, lacto and bifido looked low. But how did they do in terms of growth? Were they vital and viable in terms of culture? Well, we can see the lactobacillus once again with that no growth. But this time, I'm a little more concerned in that I have a low quantitative DNA finding for lactobacillus paired with a low culture or an inability to culture. The E. coli and the bifido cultured well. So again, how do we put those together? Well, for bifido, we had a really low quantitative number, but we know we have a reasonably strong 3+ vital bifido strain. So again, I would be encouraged that probiotics would be useful here. We took the stool, put it in a culture, and the Klebsiella grew out into a potentially pathogenic 4+. The bacillus was only at 1+. It would have taken a 4+ for us to designate that a potential pathogen. But again, the doctor always has to make those decisions based on the clinical presentation. The mycology, there was a 1+, a very mild yeast growth. You see the 4+ there. The best we could determine was that it was not Candida. So what about the parasitology? No over a parasite seen. We blend, filter, and look under a high-powered microscope. By the way, there's an option for a 1 specimen or 3 for the parasitology. I always would lean to that 3. And we also looked at the, we looked at the Crypto, Giardia, and Entamoeba, all negative. So we had Klebsiella oxytoca at a potentially pathogenic level. This is the in vitro sensitivity panel. So we can see that for R, ampicillin was resistant, wasn't useful. All the other prescriptive agents were. For the natural agents, it goes from left to right, from low to high inhibition. So that the higher the inhibition, the better. If it's halfway across or better, we're happy with that. And the oregano makes that halfway mark. The others look just a little bit better. What about the NutrEval? Well, we see antioxidant need. We do see B vitamin need and that moderate magnesium. If we look at the digestive support, again, a high pancreatic enzyme need and a moderate probiotic need. So both tests are really pointing in the direction of digestive support. I think it's interesting as well, if you look at the amino acid recommendations that are based directly on those amino acids. Because if you may recall, the patient had indicated a low protein dietary intake. This is the Krebs cycle at a glance. I just put that up there to freak you out. It's the fats, carbohydrates, and proteins. Just kidding. These are part of the organic acids. And I say that because I can always tell when I get to this page, sometimes I hear a sigh on the other end of the line, and sometimes I hear this energetic, yes, Krebs cycle. It's a pretty balanced cycle here, so I'm not going to really spend time on this today, but always happy to discuss this on the phone in detail. So what about the metabolic analysis markers, the organic acids here? How does it look on the gut? Well, again, we see elevations. Phenylacetic acid. Benzoic acid is often elevated because it's in a lot of foods and drinks because it's a preservative. But also the citramalic paired with the phenylacetic acid speak to either malabsorption of nutrients. In the case of phenylacetic acid, phenylalanine, an amino acid that's converted by anaerobic bacteria into phenylacetic acid. So higher phenylacetic acid may speak to malabsorption of the amino acid and or an imbalance in the bacteria that make the conversion happen. So again, this does speak to some degree of dysbiosis based on the organic acids. I remind you that the stool analysis is always going to be my gold standard here. I find this the most interesting. Remember, this is a patient on low protein in their diet. Look at those levels, how consistently low. Remember, too, the patient complained of fatigue. But where are the building blocks? And when I try to get a sense of, when I see such low findings, my next question is, are they eating protein and just not breaking it down and absorbing it? Are they eating a moderate or high protein diet and there's a problem utilizing it? Or are they just not eating much protein, in which case maybe introducing more protein into their diet is the key. And if you look here at the dietary peptide-related markers, there's that 1-methylhistidine we described earlier. But all of these, anserine, which converts into 1-methylhistidine, carnosine, all very low. And even the urea, further up on the urea cycle markers, everything consistently low. To me, this is a patient, if you were to get them to either eat more protein and or even to try some sort of supplement or shake just to see how that might help, they just don't have the building blocks. Neurotransmitters need this. We need this for so many things, this protein to rebuild and replenish. It doesn't surprise me that she has fatigue. Now, the essential metabolic fatty acid markers are really good omega-3 presence here. But again, as far as the omega-6s, look at that DGLA. So I certainly would want to support that as well. So oxidative stress markers, again, the lipid peroxides. Now, the glutathione looks really very good there, but the lipid peroxides don't. And by the way, the 8-OHDG beneath it is another ox stress marker, a different type of ox stress in the cell nucleus where free radicals create DNA damage. But the lipid peroxides consistently, you can see an elevation, a need for antioxidant support. The magnesium is a little low in the reference range, and there was a moderate recommendation for that. Okay, so now we've walked through both the NutrEval and GI effects for this patient. And what do we see? Well, you know, we did see just over 200 in the pancreatic elastase, so a low normal. There is a recommendation here for pancreatic enzymes. We saw also on the right there imbalances, and we saw a potentially pathogenic bacteria. So probiotics, so we're in agreement here. Also, if you look at the commensal balance on the right, the good news is that she's just on that yellow edge, but the bad news is that that relative abundance really speaks to a need to replenish, just as the need for probiotics indicates on the NutrEval. And of course, the GI effects really showed us some low, likely low low amino acids. Certainly all these amino acid needs stand out for this patient. So what are our treatment considerations? Antimicrobial natural agents rebuild with prebiotics, probiotics, and fermented foods. That really low relative abundance. Diet, increased protein, more food, more unprocessed foods. Emphasize brightly colored veggies and fruits for antioxidant support. Remember that high lipid peroxide finding. Pancreatic enzymes with protein-containing meals. continue omega-3 supplementation. The omega-3s did look very good, but that supplementation seems to be getting the job done. And maybe switch to a more professional multivitamin, one with more magnesium, maybe more B complex as well. And then again, follow up with the Rhythm Plus with CAR, cortisol awakening response, for insight into cycling hormones and adrenal function. If your HPA axis, if you're secreting lots of cortisol, you're going to impact sex hormones, you're going to impact insulin levels, you're going to impact thyroid levels. So this is a balancing act, and just one thing isn't enough. Really look at the overall big picture. So here are some points that I just wanted to emphasize. First of all, the GI Effects stool testing is a more specific indicator of gut issues. Again, if I'm looking at organic acids and amino acids in the NutrEval, that's good information. And if I'm seeing a clinical picture that reinforces those organic acids, I might treat based solely on those organic acids. But if I want to dig deeper, I'm going to want to have that GI effects to see what are the actual levels, what is actually growing culture, the various specific measurements. I use the term functional recommendation, and that's what we do in the NutrEval. We utilize an algorithm. So we're not measuring the B vitamins directly, but we're looking at things like we talked about xanthoranic acid that requires B6 in order to be broken down. High levels of xanthoranic acid in the urine, functionally, B6 is needed. And so the algorithm utilizes all that information. Even in situations like a direct measurement, we may look at magnesium directly and it would be in the reference range, but we might have more of a recommendation to supplement because the algorithm is going to look functionally at other markers in the test that depend on magnesium as a cofactor. DNA as a quantitative measure versus culture as an insight to viability in the GI effects profile. In other words, DNA gives me a number. I use it because anaerobes are the majority of the gut microbiota, but very hard to culture. So it's a way to sidestep culture and get a number. And so I can statistically look at the distribution of those anaerobic bacteria, whereas culture is about viability, the strength to grow out in a culture medium. Now, we didn't talk much about that. We didn't talk at all about plasma amino acids versus first morning void urine. Both of the tests that we looked at involve first morning void. There are two types of NutrEval, different kits, and the only difference is you can use plasma for amino acid measure, or you can use first morning void. That discussion, really, plasma amino acids give you more of a steady state over time of the level of amino acids. First morning void, you're looking at a shorter time frame in terms of when you had that protein and the level of amino acids as a result. They're both excellent ways of looking at amino acids. And then the new interpretation at a glance and commensal balance, they are not diagnostic, right? They allow for pattern analysis based on patients who have run the GI effects in the past. The idea being, when you look at those 24 commensals, you can look at them and say, oh, I noticed the Prevotella is high and this one's low. What does it mean? Everybody is so unique. Everybody's microbiota is so unique. So it's difficult to kind of put that puzzle together from patient to patient. That's why we went and added these interpretations, commensal balance, where we say, hey, what if we could compare our balance to patients in the past who are healthy screen cohorts, who had diagnoses, so that rather than just picking out one here and one there and wondering what that means, look at an overall distribution of the pattern. How does my microbiota compare to these healthy cohorts, these patients with mood disorders or diabetes or IBS or IBD? And I think it's a great addition in terms of analysis. But remember, it's not diagnostic. It's a look at patterns. And consider the recommendations provided, but always feel free to adjust any recommendations to the clinical presentation. We're not seeing the patient on our end. We're looking at the findings of a test, but you have that wonderful honor of treating that patient standing in front of you. And so our recommendations are just that, recommendations, suggestions, but always feel ready to make changes based on the clinical presentation. And that's always the key to really utilizing a lab in the best way possible. So again, the objectives of this presentation were to identify concepts that connect nutritional assessments and stool testing results, and to provide interpretation and application of laboratory results, to discuss strategies helpful for treatment plan creation. So the NutrEval for nutritional comprehensive view, the GI effects to get a look at the gut microbiota, and to be able to compare against other patients who have also run the test through DNA findings. Any questions?
Excellent presentation, Dr. Goldman. Thank you for that. That was wonderful to see how those tests tie together and the relationships there. We've received quite a few questions from the audience. So let's start with this one. What would a GI effects result look like in a patient with SIBO?
It's a great question, and it comes up a lot, and I think I mentioned along the lines that, the GI effects is not a SIBO test specifically. We do have the 2-hour and 3-hour breath test for SIBO, and if I'm suspicious, I'm going to go to those tests. However, there are certain markers that can reflect SIBO. For example, the relative abundance, an elevated relative abundance relative to the healthy cohort often is associated with a SIBO patient. Now, does that mean always? No. I've seen SIBO diagnosed patients that didn't have a high relative abundance, but oftentimes you see that pattern. Sometimes too, pancreatic enzymes that go down. So a lower pancreatic elastase can be a result of SIBO. Oftentimes malabsorption comes with SIBO. Remember, SIBO isn't really so much about a frank pathogen in the small gut. It's about commensal anaerobic bacteria that belong in the colon in high concentrations, but not in the upper gut where it gets in the way. So malabsorption can occur with their presence. Higher higher fecal fats, for example. If you have a lot of bacteria in the upper gut, it's going to eat away at the bile salts, less bile available to break down and absorb fat. So malabsorption is certainly an indicator. The short-chain fatty acids also. Remember, anaerobic bacteria breaking down fiber. So if you have more of those anaerobes higher up in the gut, when you start eating fiber, you have a head start in that breakdown. So oftentimes, I will see very high short-chain fatty acid totals. Now, having said that, sometimes I see just exactly the opposite, very low short-chain fatty acid totals. And the key there is that some patients, they may not know what SIBO is. All they know is, hey, when I eat fiber, I get really bloated and I get gas and I have constipation or diarrhea, so I'm not going to eat much fiber. So patients may, on their own volition, really limit their own fiber. In that case, you might see a SIBO patient with really very low short-chain fatty acid totals. Although if they are eating fiber, you'd expect it to be pretty robust. And again, if you're giving fiber as part of your protocol and the patient is bloating more and feeling worse, that's a key indication that you want to test for SIBO.
Excellent. Thank you. Another question. Any tips on when to give probiotics to a patient who's on antimicrobials?
Another really good question, and it comes up a lot in a clinical setting because you see a patient and you see them depleted, as we saw in that second case study. And yet there's a need for probiotics and prebiotics. So how do you do that? You can provide both probiotic and antimicrobial therapy. The key is making sure they don't meet up in the stomach and neutralize one another. And so typically, I've heard a range anywhere from 2 to 4 hours. I always think 2.5 to 3.5 hours. In my mind, there may be some variation and thought out there about that, but you want to make sure that the probiotic is not going to meet up, that it's already emptied from the stomach before the antimicrobial could come and neutralize its effect.
Thank you. Thank you. Another question. How do you get patients to take all the necessary supplements at the required dosage? That question referring to the NutrEval.
Well, another interesting question, because we're making recommendations here. I find that one of there's a few reasons why it's always important to test and get data. You want to know. You want to have evidence. I find it's also very motivating to a patient if you want to give them supplementation and perhaps they're resistant to it, or you want to change their diet and they're resistant to it. So first of all, I just think it's motivating to see that these specific needs have come up, and that the physician is taking those recommendations and calibrating them based on what they're seeing clinically. I think with B vitamins, I tend to lean, you'll see some that are more elevated in their needs than others, but I like to see a B complex as an underlying support. I believe it may help with the absorption of other B vitamins that you might take. I also want to think in terms of foods. One of the things that we didn't talk about is the interpretation at a glance section of the NutrEval. And in that, if there was a need for, say, B6, the last talking point or arrow in that would be foods. So I also always think about what kind of foods I can use and not only depend on supplementation. And I think that's really key.
I agree. Those interpretation at a glance pages are really helpful to be able to circle some foods and say, let's meet these needs through foods, and then we'll focus on a few other needs through supplements. I think that plan typically works pretty well.
Yeah.
It looks like we've got time for maybe one more question here.
Okay.
We're
in the bonus round.
Yeah, it's bonus round. So on the first page of the NutrEval, looks like sometimes you'll see a borderline or a high need for magnesium or zinc, for instance, and then you'll see the elemental markers itself appear to be normal, in the normal range. Can you talk a little bit about why you might see that?
Yeah, I think it goes back to the concept that we had spoken about a little bit earlier, which is we're looking here at functional recommendations. When you have, let's use magnesium as an example, how do you come upon a magnesium reference range? Well, you screen a certain population to whatever criteria, you put it in a bell curve, and you statistically break it down into standard deviations. And you can say, based on, let's just use as an example, a healthy group, that this much magnesium is in the center of the bell curve. So if you're right there, then you're right where a healthy person should be. Well, that's one way of looking at it. But everybody's different. And so what if you have that same amount of magnesium as that overall bell curve indicates as a standard deviation, but there are a lot of other markers? Like on this test, ethanolamine has to convert into phosphoethanolamine. Some of the markers on the test. If ethanolamine is really high and phosphoethanolamine is small, that's a magnesium-dependent pathway. If I start, and by I mean actually the algorithm starts to see those kinds of findings on the test that count on magnesium as a cofactor, but that they're wanting, then it's going to ask for more than just what might be considered a maintenance level or the lowest level of magnesium supplementation, because for that individual at that specific point in time, they need more than one standard deviation in a bell curve. They need a functionally higher recommendation. And so you'll see that where the magnesium looks good measurably, but that the algorithm has determined that you might want to consider a higher level of dosage for them, a higher dose level of magnesium. And again, the doctor always has to make that final decision.
Thank you, Dr. Goldman. So that was a great presentation. In the interest of time, we need to bring this presentation to a close. So for additional educational materials, we'd like to encourage all of our attendees to visit our website, www.gdx.net. That is listed on the next slide here. On the website, you'll also find sample reports, specimen collection instructions, and other information about Genova profiles. Also, please feel free to contact our client services team at the phone numbers listed here if you have any additional questions or need assistance in setting up an account. We also offer complimentary appointments with our medical education team, which includes Dr. Goldman. We'll answer questions about testing, including choosing the right test and reviewing test results. Finally, want to encourage all of you to look for our upcoming webinar. I'll be presenting next month on the topic of the NutrEval and Ion, looking at a couple of cases in in two different athletic patients. Finally, we'd like to want to thank Dr. Goldman, thank all of our attendees for joining us today. Thanks again, Dr. Goldman, for an excellent presentation.
Thank you. It was my great pleasure.
Take care, everyone. Have a nice day.